All right, we're gonna jump into it. Dan's over here. He's deciding if he should go Clark Kent or just straight.
Maybe I'll just leave it.
A little bit different podcast. So this is the first time I think ever over the 9 years of podcasts that I've had a patient on. Which Dan's not just a patient, also in the medical profession, which we're going to dive into. But well, I don't want to give away too much of the story because that's what the podcast is about. Is why Dan is here. So we're just going to jump into it. It's Dan Marvin. I'm not going to give away any more hip information since you're a patient. But kind of give us the lay of the land of what were you doing in the medical field and why did you get into medicine in the first place?
My original plan actually was years ago was to go be a physician, but somewhere along the lines in college, I decided that I think I got distracted by other things, probably girls, and decided
Natural. Yeah.
decided that, man, all that schooling probably wasn't going to work out for me. So, but I did know that I wanted to stay there somewhere. So I ended up doing nursing school at UAB, and then mainly loved pediatrics, and so that was kind of my love, and is doing pediatric medicine, and so. And the way to becoming somewhat like a physician in that way was to become a nurse practitioner, and that's kind of the short of it. Is ended up getting my master's at Sanford in family practice, and ended up practicing in emergency rooms because I just love the practice of seeing patients treating acute illness and in emergency situations, and then being able to hand them off would be nice. Yeah, the kind of, I guess in some ways, just have the energy, and then
the fast pace,
and always moving, and so it was really good. I did adult emergency medicine for the first few years of my career, and then me and a few buddies of mine went to Children's Hospital in the emergency room down there and started a group of mid-level providers down there, and so that's kind of where I was, and where all the stuff that we're probably going to talk about kind of started to occur. So,
was that ever tough, like just being in pediatric emergent care? Because I mean,
oh yeah,
it's tough with anybody. Because I mean, they're all humans, but like seeing kids in some of those scenarios. I mean,
yes, I think that would go along with like some of my story, because I think just what you see on a daily basis, the trauma, just the things that you have to deal with on every single day. I think it's one thing to see that stuff in an adult who has lived a significant period of time, and then to relay that back to go to a child who, infants, bad things that happen with infants, to, teenage, all the way up to teenagers, things that, they're supposed to have this long life, and then all of a sudden it's cut short, and just really being able to having to suppress all that emotion and kind of just keep working. And so that was kind of a very difficult thing. But yeah, that was hard.
Yeah, and we'll kind of table like you said, what effect that may have on what we're going to talk about here pretty soon. But is there, I don't know this because I've never, obviously been in that world. Is there a high prevalence of avoidance behavior with like emergency room physicians and NPs and PAs and things like alcoholism or activities to try to like get rid of the thoughts, or is it just kind of a normal part of practice and that you pick that? And
I guess I'm trying to make sure I understand your question.
I guess if I, like a soldier, they have like, they go out and do stuff, and then like to, drown stuff. I'm not saying it has to be alcohol. It could be, risk-seeking behaviors.
Yes.
Could be, whatever it is. Yeah. You see some correlation of people that are in that are also going to have to do something to offset that kind of like trauma. Or
I do believe. I think mine was probably exercise. I mean, I was in local CrossFit gym, and I was there on my off days, sometimes 2 or 3 hours, 2 or 3 workouts. Maybe some drinking here and there, but most of mine was just keep moving. I think I was never able to slow down, so I'd leave the emergency room and then go keep moving.
So that fast pace just took over.
Yeah, just kind of was just what I knew because that's how I dealt with it.
Yeah.
So because it was easier to move than to sit still.
Like, sit with your thoughts.
Sit with the things that I'd seen.
Well, let's kind of dive into it. So how long were you in practice before stuff started going south?
Let's see, I started practicing as a mid-level since 2000. So and I ended up kind of that when I started getting sick was probably 2015, I think.
It's almost 14, 15 years.
Yeah, and I was a nurse before that in the emergency room there at Children's.
So 2 decades worth of work before anything happened. And so give us just a lay of the land of like what were some of the first things that did start happening that, was it just everything blew up at once or slow little like clues that something was going on?
I think it was one of those things where in the beginning I think it started to manifest itself in anxiety. I think it was a physiological response to probably not just work, but I think also with family and just kind of the whole picture at the time of having a stressful job. We have one of my sons was born with PKU, and so there's a lot of stress that goes along with kind of getting him fed and the formula and then just multiple other variables. But it was just a moment of just kind of high anxiety. I think it was a physiological response to just the stress that was there at that moment in time. But it just kind of progressively got worse. And then it started to, instead of just having like the feeling of chest tightness, short of breath, to just a feeling, you're shaky or your mind's constantly racing. I think eventually it turned into pain.
Mm-hmm. So what was the first thing you experienced outside? Did you ever have panic attacks or just high level anxiety?
Well, I think I've always been kind of an anxious soul, so to speak. I think
it was hand in hand with one of the fast paced settings.
Yeah, I think now that I've done a lot of work, I can trace my anxiety back to my childhood and various variables back then. But I've kind of always been that kind of a nervous person, but it just, I don't know if there was I've had lots of time to think through this. You think I'd have a better.
Well, we also know that like human memory, like you start to like change things in the timeline itself.
Yeah.
Like, either fit a narrative or just you don't remember it like it actually happened. So especially, I know your history with like medications. I'm sure it got blurry there in the middle at some point too. But what was the first major like pain thing that showed up?
I first presented with one day in the emergency room, started having pudendal neuralgia, is essentially what it started as. It was just a pain that all of a sudden I was like, man, this is weird. It was a tingling weirdness that hurt to sit down or just irritating. And at the time I was working out all the time, so I
correlated to that.
Yeah, I correlated it to that, but I didn't really stop working out at the time. But I just kind of became more and more hyper focused on the pain. Mm-hmm. It just kind of became overbearing. Where at work I would have a cushion that I'd take with me to sit down, and it was just a bizarre. I became so focused on it. I couldn't. It just was so overwhelming.
Yeah. And then did that transition into like legitimate low back pain outside of that?
It did. So it went from the pudendal neuralgia to low back pain, and I think somewhere along the line, that's when I presented to you for the first time.
I should have looked at your notes before we did this, but I'm trying to remember, and you'll know better than I will probably. I think when I saw you, by the time I saw you, you were having low back pain. You were also having some cervical pain already, and that's what was kind of starting to blur. Like, well, is this like biomechanical or workout related, or what's going on here? Right. Can you remember? Were you having any peripheral stuff?
I was having some weird, I guess, twitching, muscle fasciculations, and then I would be doing procedures in the ER, suturing or spinal taps, and my hands would start to just do weird things, and like I can't explain what's going on here.
Like uncontrolled movement, or you just?
I think some of it was uncontrolled movement, but then like I'd get done with the procedure and I'd come out and my hands would be just stiff and just numb, and it was just bizarre. I remember one specific time when it really scared me was I was trying to IND an abscess of a patient, and I was trying to. It was actually in an awkward place, and I was trying to push my body part this way to kind of get to where I was, and all of a sudden I just had like this jolting pain up my arm, into my shoulder, into my neck, and I had to like literally walk out of the room to get my composure because I had no idea what had just happened, but it really freaked me out.
Were you able to go back in?
I was, but I had to literally go out, get the nurse that was in there with me. I said, "Give me just a minute. I'll be right back." So then I had to go back and then finish the procedure.
Did people that you were working with know what you were dealing with?
They knew that I was in pain,
but at the same token, you didn't know what you were dealing with.
But at the time, I didn't really know either.
So early on, when no intervention, like surgically or anything, like were you doing anything medication wise on your own accord? I mean, if you're in this realm, like how's this go? Just asking, like, I don't know, again, like, are you seeing somebody for this, like that can prescribe something? Or are you kind of like, man, I know what to take if I'm dealing with pain, like, or were you doing anything at all like that?
Well, I think originally it was just ibuprofen, all the time. Maybe some goodies powders, probably.
I've had patients that it works for,
and Monster Energy drinks on a regular basis.
That aren't from the South, I know what we're talking about.
But I think I originally started on like Klonopin, which kind of really helped me out in the beginning, just to kind of calm everything down.
Plays in the anxiety part of it,
And then what ended up happening is with all this low back pain, originally I went to see my internist, and they did, of course, a prostate exam, and then said, well, it's not that, and then let's do a CT of your abdomen just to see if there's anything sitting in your pelvis. And so it turns out that was the moment when it first kind of came out that I had a bulging L5 S1 disc, and so that's kind of where the focus went to.
Right, this external focus before pudendal pain, carrying around a donut. Now you get an imaging finding, right? That wasn't usually for something. Which I actually kind of like that. I mean, based off the pudendal stuff, obviously they went through prostate exam, abdominal before like lumbar, which I think is pretty smart. But now you and I have had numerous conversations. You know the research well as I do about imaging findings and lack of being tied to pain or whatever. So it's kind of, looking back, like, what are your feelings on that now when you knowing how did you handle that? Did you think, oh, that's what's causing my pain immediately? Or,
well, I think when you're in so much pain and it's, I mean, you're talking at the one point I could barely walk.
Yeah.
It's I mean, it's hard. And I think being in a medical profession, we were trained that there has to be something structurally wrong. So all of a sudden, here I am on the disc. That has to be the answer. And so that's kind of where the focus went real quick.
Yeah.
And that's where I kind of got stuck in this moment of, this has got to be fixed. We got to figure this out because.
And humans are designed we're like heat-seeking missiles for problem solving when it comes like ailments, like internally. Like I see it all the time. Like people are just like, what is it? What's wrong? What's wrong? Label it. But we know how bad that is from a nocivic standpoint, but like people want that. Like you tell somebody they got Achilles tendonitis versus like a sensitized nerve that may be worse when they run. And they just label. I mean, I hate to say that. They just want to know. So you get a CT scan that kind of ancillarily finds lumbar disc herniation. So from that point, what happened from there? Like, what was the timeline of interventions that started to occur after that?
Well, I think I started seeing you intermittently. You're doing, lumbar. I cannot specifically recall.
Yeah, exactly. Probably for clinicians like McKinsey protocol, looking for, because if I remember correctly, you also had, which you've had for a long time, like kind of bilateral peripheralization, like across like gluteals. And I would have to look at your notes. I don't think you had complete peripheral stuff like down either leg though. I think you had like diffuse back pain in your glutes.
I had no radicular pain in the essence of, would explain, a disc and
like herniation, mechanical sensitization or anything.
And so, but after that, the pain moved from my back to my neck to name it, pretty much.
And your neck became more severe.
It did.
Was that after surgery?
I think it was beginning to erupt at the time when I had the surgery on my neck. On my back.
Yeah.
And I think after the surgery,
which you had, you had a
L5S1 fusion.
And then I remember succinctly, because again, timeline's hard for me to determine. We'd have to go through every note. And I remember you coming in and you were having neck pain, and it was kind of like ebbs and flows. It would be really bad, but then you'd be literally like, it's not that bad. And you went golfing, and it was so bad that you literally like were getting sick, like nauseated due to pain.
Yeah.
And that's where I was like, dude, you already knew something was up because you had low back pain, you had a fusion, nothing changed on the back end of the fusion. And then you started having neck pain, and I think you were having more upper extremity symptomatology. And then kind of nauseating pain. That's where I was like, this is, and I think we were doing a little bit of neck stuff, and that's where I was like, this, not like I'm out, but something else up.
Yeah.
So when the neck stuff started happening, where in that mix did the stimulator, was that way later? Like after
it was way later. I think the timeline, in essence, is I had the back surgery, and at the time I was still working. I think after the surgery.
Yeah, that's a good thing to point out.
I took some time off. Of work and had the fusion, and then essentially originally thought that it was successful, but then not too long after that realized that that wasn't going to be the answer. And then that's when the neck really exploded. And then the time frame after that was, I think I just became so hyper vigilant about every single thing in my body that I just could not. The pain became so out of control that it was unbearable. And that's when, my primary physician had prescribed me in the beginning, Lortab or I think it was hydrocodone or some variant of that. And that's kind of what became kind of the slippery slope then too, is because, here I am, going to work and, high dose pain meds and Klonopin and
already having like motor function.
And then that's kind of once, during this time, my emotional self was on the downfall, and then just my ability to, I saw, I was probably going to lose my job. I wasn't going to be able to function, and I just kind of deteriorated from the emotional standpoint, depression and then somewhere around that timeline, I can't remember, maybe that was late 2016, I think, maybe 17. I don't know, I can't remember exactly specifically, but that's when I kind of had an internal stimulator put in for my neck.
Okay. And then that was no bueno.
No bueno.
Okay. And then during all that, also, I don't know, again, before or after, but like things like gabapentin came in.
Yes.
And that's where I mean, this is nothing, it sounds derogatory, but you come in and, I mean, you literally were having trouble speaking, which then we couldn't tell like medication or other stuff because, I mean, it was literally, I mean, you knew it too, because, I mean, both from a medical professional, but I mean, you literally would be like, get frustrated because you couldn't like get words out. And, at some point pulled the trigger on disability from work, because he had to. So there, and then it kind of like, as well as I do, like all this stuff, it's like chicken or egg, right? Like anxiety may have started this reaction and now you go into a depressive state, which then builds back on the reaction. And you got medications that are subduing pain, and pain may be a communication. I mean, this is where chronic pain becomes, such a, I mean, it's so hard to touch, right? Because you don't know what's going on. So at what point, so you've had lumbar fusion, you're doing treatment with me here and there. I think we kind of started being way more hands off and like, we gotta, especially after the pump or the stimulator. You didn't have that stimulator that long though, right?
No. And I was really, the stimulator actually became so annoying. It just, I think it's when you're in a hypervigilant state, you can feel so. I kind of consider myself a feeler at baseline, but then you throw in a stimulator that, originally when they do a test run with it initially, but I was on narcotics when I had and so the question was,
which one's helping?
Which one's helping? So I went ahead and got it done because it seemed to help. But then once I kind of came down off narcotics a little bit, then I was like, oh, there's this little zapping in my neck and I can feel it. And then I had to have it removed because it was literally driving me bonkers.
Yeah. So like that, again, hypervigilance kicked in on something new. So then that occurs, still on medication because you're still trying to manage pain as best you can with this stuff. When did you start changing how you were looking at it? Because you're still kind of at some point on seek and destroy, right? Yeah. It's lumbar fusion, medication, stimulator. When did you start thinking like, dude, something else going on, and start looking into this chronic pain model? Because correct me if I'm wrong, were you aware of like this kind of stuff before this happened to you?
No, absolutely not. The medical model was the only thing that I knew, and that was, structural. There had to be a reason. Right. So I went on this long journey to figure out what was wrong. So I went to the Mayo Clinic.
And you went to the Mayo into their pain management program,
their pain rehab program, because I was so desperate for a cure. And oddly enough, I think that was down there. Essentially, I was there for 3.5 weeks, and this is after seeing their rheumatology, their orthopedics.
They're trying to triage you,
right? Yeah, and they said none of them found anything that was significant. And so great. So, but we have this pain rehab program that we think you fit in great. And I'm going, well, okay. Insurance doesn't cover it, but okay. So I stayed there for 3.5 weeks, and essentially the program, looking back at it now, it's right on in essence of, they get you wean you off your meds over this time period, and then they get people moving through physical therapy and then walking. I mean, some people go in on wheelchairs and then come out walking. Right. It's actually ridiculous how some people were able to overcome these things. But a lot of it is, I think at that moment in time when I went into the program, like the day before I entered the program, I got a diagnosis of small fiber neuropathy.
Go ahead and ask, who made that diagnosis?
One of the neurologists at UAB. Okay. Yeah, they did a skin biopsy.
Right.
So I literally, it's like the day before I was down there actually in the first day, and I get a call and says, well, you've got some small fiber neuropathy. I'm sorry, you're going to have this the rest of your life, and it's going to hurt. I'm going, great. So now I'm in
So now you enter a pain management program with a diagnosis that somebody just told you you're going to change.
Right.
Yeah.
So that was helpful.
Not funny, but
it was. You're looking back on it now. So then all of a sudden, I was thrown into this program where the theory is that this is where the beginning of some of my change in my philosophy towards this was. was that they believed in this hypervigilance where your brain your neurological system gets revved up. And so your pain obviously is going to increase, and the goal is to kind of turn this down. And doing that, you have to move, you have to sleep, you have to do all these things. And so a lot of people, I was still fairly active, but there's people much worse than me that would go in, have crutches or what have you, and being far worse than I was. And that's the thing, is like I was still fairly functional in essence, but the program there, you almost have to kind of be ready to heal in some ways. And at that time, I had just gotten this diagnosis, and then I was thrown into this program where this guy was telling me, "Hey, this is all in your head."
It's almost like you're set up for failure,
right? So basically, I was there for 3.5 weeks. I didn't sleep for 3.5 weeks. Needless to say, I got, I was moving again, moving better, but I got home, and really none of my environment at home changed. My situation didn't change, so I kind of was thrown right back into where I was before. And then just this theory of, hey, the pain is all on your head, kind of, which is not really what he was saying,
right?
But why, this doesn't make any sense, and so. But then that led to just kind of another spiral down into the abyss, as I call it, to I'm never going to get out of this. This is awful. And then back on medications again. And then, basically being non-functional, trying to destroy my marriage and my family and everything else, because when you're in pain, you're angry and frustrated. And
I remember I saw you some point after Mayo, and I remember you literally telling me, like, that was a waste of time. Like, they just told me that you were like, they told me it was on my head, but now I got this diagnosis, and that you had this like diverging paths, and you're like, you just tell you, like, what the hell, like, you know what I mean? So stuff gets kind of dark maybe at one point. Like, what was a turning point then? So if you're just like, man, I'm never going to get rid of this, like, what do you do? Like, where did you start saying, well, I got to do something different, or what was the catalyst?
I think after years of being on narcotics and being in pain, I think it came, I don't know if I have time to tell a quick story, but this is the honest truth. I was on the back porch. I think it was maybe early afternoon, and everybody was going to school, and, I had a Butrans patch on. I was taking morphine sulfate every 6 hours, and I was also taking oxycodone in between. So I was
not be able to feel anything.
I was kind of a walking zombie.
Yeah.
So, but anyway, I was on the back porch, and I didn't really drink a whole lot, but I had a beer. I had a beer in my hand, and I had, I think, 2 10-milligram Percocets in my hand, and I remember vividly looking at the pills in my hand going, there's got to be something more than this, than what I'm living. But I said, okay, well, I'm going to take this, drink this beer, and then we'll figure it out. So that's what happened. I mean, that's literally what happened. So then after that point, that's really what happened. I was like, well, I'll worry about it, but I'm going to drink the beer and take the pain meds, and we'll deal with it. But that's when I decided, well, something's got to change, and I got to find what it is. And that's kind of when I stumbled across, I think I told you before, I stumbled across the book, Healing Back Pain by Dr. John Sarno. And after reading that book, that's kind of when everything changed. That's when I really began to believe that I could probably heal from this, or if not heal, manage it, or in some way improve my being. And that's kind of what ended up happening. Is I read that book, and we can go into more detail about that. But
I was going to say, what was there anything specifically in that book? I mean, he's kind of I wouldn't say a pioneer, because it's not before pain neuroscience started being talked about in the 70s. Just didn't become a popular kind of belief until we started running into a bunch of musculoskeletal pain in the 2000s. But what in particular in that book, was there something like, oh yeah, it made sense or clicked, or you think it was just time and place of you needed something and that was a good catalyst?
No, I think really what it is, and that his theory of suppressed emotions like rage, cause autonomic system dysregulation, and a lot of times it's subconscious. It's not in the conscious mind, and the brain initially kind of puts up these defense mechanisms in essence to protect you from these emotions.
Run amok.
Right. And so, and the problem is it's hard sometimes to bring these subconscious emotions to the conscious mind. And so, but really digging into that is how personality traits such as perfectionism, people pleasing, all these things, I kind of saw myself in these pages kind of like, man, talking right to you. It was like, man, this is some of my upbringing, just this frustration in my career, like it kind of all had imploded at this, and it all made perfect sense to why this may be occurring, and that's where I really began to like, oh, this is it. This has got to be it.
What was some other stuff that you started looking into after his book?
After his book, I think I read like all his books. And essentially, I think there's the Divided Mind. The best one is the Mind Body Prescription, in my opinion. But it's just that is.
Are you good?
Michael. But that's when I began to really go on the search for this autonomic dysregulation kind of theory of why this may be going on, and I stumbled across an app called Curable Health. I don't know if you've heard of it, but basically it's kind of an app that helps people with chronic pain kind of go through different things, different aspects of their life, and kind of it actually has like exercises within it that you do on a daily basis to kind of take just a good look at what's going on in your life and how these variables can be playing into your issues. And then so I found the app and I started doing these exercises, and a lot of it involved some of it is meditations, especially when you feel kind of uneasy, really anxious, kind of learning to turn down the nervous system, because that's really what this is all about, is turning down the nervous system. And that's when I found out about Curable Groups. And so Curable Groups is a 12-week program where you once a week you have a facilitator. At the time it was on Zoom. It is on Zoom now, but so you're meeting with a facilitator and then people from around the world that suffer from chronic pain. I think it's a group of 12 of us, and every week you have like some topic. Like one is like identity, another one is like childhood trauma, like all these things to take a look at to kind of see how this affects you, and you have exercises within that, and then you talk about it as a group.
It's the same group for the whole
12 weeks. Cool. And so that part of that just really opened my eyes to really learning that, hey, this is more and more how I had lost my identity, who I was, but really that really wasn't my identity. It was just something that I had made,
like a wall,
put up, and then going back to childhood issues of things. Nothing really bad happened to me, but just normal frustrations.
How you formulate your subconscious around environmental stresses, strains.
Yeah. And so, and some of it too is just, learning, gratefulness and all these other things that kind of go along the lines of, because when you're in pain, you're in this absolutely frustrated state of mind that when your pain is 10 out of 10 every day, I mean, you're searching for anything and everything that's going to help you. And so, but this program kind of really, and they have physician facilitators that come on that specialize in this. And I think what they're calling now mind-body medicine. They come in and kind of help have discussions with you, and you can ask any questions. So That was really useful in my recovery, and that's when I really began to learn to turn down the system. And really, the key too was to not become so hyper vigilant about every single thing in my body. So then that's the other thing that really was hard for me, was anything that felt funny or twitched or did anything, all of a sudden my mind was
right focused on.
Yeah. And so that was really learning how to, deal with some of the things in your life that maybe you wouldn't have thought of, that could be the reason why you're having this dysregulation, neuro dysregulation. And so that was really useful. And so after that, it was kind of, since then, it's like I weaned myself off narcotics and I began moving again. And that's kind of been, I guess that was about 3 years ago, I think, when I did that program. And a lot of it becomes like a daily practice. It's daily, sometimes journaling about how you feel.
That's what I was going to ask. So just for somebody that's listening, that's like never done this, but maybe dealing with this. So you said meditation, but like, what were some of your like main things like that you either still do, or you're like, these are like my go-tos?
I think the biggest thing, I think, in dealing with this neuro dysregulation, I think if that's what we're calling it, is movement. I think that was really the biggest thing. I think when you get in a hypervigilant state in pain, you just don't want to move because it hurts. Everything hurts. And so you have to learn to, kind of move slowly, become outcome independent, meaning, okay, this is going to hurt a little bit, but I can deal with it. And then gradually increase your activity. And that kind of helps, gives you that dopamine hit to kind of settle things down. And so that really was enough, like I could move again. And so that was a big one. The other things would be meditation. I think I began to meditate, in the mornings and then the evenings, and then when I began to feel very uneasy, then take what I call now a momentary pause and say, hey, I need to take a time out and go and breathe a little bit. And I think we had lots of discussions about breathing, but started doing that as well. And I think the journaling aspect of that was really important in the beginning, because it kind of really, because the type of journaling that I ended up learning to do, you can sit there. I don't like to journal and just, this is how I feel.
Right.
It's really, in essence, if we're trying to get out the subconscious emotions and feelings, then we really got to write things and how you feel, like literally how you feel. And if you're angry at somebody, then you write, hey, I'm angry at this person and this is why. And then you just get out all the, cussing, all the whatever it is that you need to really make sure you're getting these thoughts out. And then afterwards you tear it up because you've got your thoughts on paper and
gone.
None. Now it's not a magic. It's not a magic, but it's definitely something to
outside manifestation of what you would hope like meditation is doing, right? Like the thought presents itself and you're able to just like observe it and be like, yep.
Yeah. And that's the whole thing, is it really is too, is really learning to, you're not your thoughts, because that's a constant war that I had, and I still have it. I mean, it would be a lie for me to sit here with you and say like I don't have pain.
Right.
I do have pain. Some days I have bad pain, but it's one of those things where it's just not something that's going to disrupt my life as it once did. And so, but yeah, those are some of the things that I do to kind of help downregulate my system.
We've talked a lot about this. One of my things that, and I don't know for sure because it's just like outside observations, like you talk about, childhood trauma and kind of like these subconscious, I don't know, walls or whatever, palaces that we build. Like I always think about people that are in like, third world countries. I mean, the stressors on them compared to what we have are technically a lot greater. Now, I'm not going to say that you don't see it, because maybe they just don't have the ability to present with it because it wouldn't be available to say, hey, I'm in pain all the time because you're just worried about what you're eating, that night. Like, do you have any theories as to why this is becoming so prevalent outside of like mainstream stuff? Right? We kind of think like, man, we're moving less overall. So now the ability for pain to become greater. Like, is there anything that you've kind of thought about? You're like, man, I really think that this is why we're seeing more of this, or this happened to me outside of just like, past trauma and kind of subconscious cueing.
I think what I believe is I think we have become, because a lot of this work that you do is really kind of going and digging into a part of yourself that maybe you don't like to see or you don't want to see.
Mm-hmm.
And I think a lot of that stems from, we all have ugly parts, right? We all have this part of us that we don't want, I don't want Beau Beard to know about who Daniel Marvin really
we're all putting the mask on.
Right. Yeah. But see, and I think, to me, I think we're kind of in this part of where people just aren't really good at being authentic. They're really not good at being real.
Yeah.
And I think, and some of that, I think, is obviously a good thing in some ways, but also it can be very detrimental to your health, because if you're really not able to be emotionally mature and to be able to deal with the things that are in what I call your shadow self, that you really can end up suffering for a long time. And I think there's a lot of, we're just not good in my opinion, in feeling our emotions and being authentic and being real. And it's that fear of letting people knowing who we are. And if a lot of people say, and I agree with it, like fear is the fuel for chronic pain. Because you fear everything.
Yeah.
So I don't know if that's a good enough answer.
I 100% agree with it. You think about social media creates a ability for people to front that, like, which we know that's just facade, but then like you think about how transactional and fast-paced stuff is, right? Like, I need to be able to communicate and, fight the interference and noise of all the stuff coming in. So it's less conversations like this, less authentic conversations, but then also, people don't have as many interactions socially, so that it doesn't even present itself.
Right.
And like, one thing that I've been very aware of, and I'm sure this happened to you at some point, maybe a little bit different, but like, I would come home from work, because we're in maybe mine's a little more social than yours, was an emergent setting, right? Because I have to kind of create a little more buy-in when somebody just gets wheeled in on a gurney. But like, I would go home some days and like, I don't want to talk to my wife, because I'm just like, dude, I'm done. Like, I did my social thing. That's not good at all. And we both do the same thing. So you get two people, she's very social, I'm a little more like, I'm going to recharge the other way. I saw that like, that can't happen, and you just got to be aware of those things and, kind of push away from like what feels good for me, which would be just go sit by myself and, hang out. I'm like, this is great, but not great for a relationship. So I 100% agree with that.
Well, and I think when you're in pain, your tendency is to isolate. Like, you're a victim. All of a sudden you're miserable and it's just you.
Well, you had even voiced to me a couple of times that nobody, whether it's your family, like, you're like, nobody understands, like, I'm in pain and everybody keeps telling me that it's this or that or whatever. And you're like, they just don't get it.
Yeah.
And I'd be like, I know what you mean, but I can't. Like, same token. So you're putting yourself on an island because that's what you feel like is going on.
Yeah. And it's crazy how, you can get so lost in isolation because you get lost in your mind, and it's just a very miserable, dark place to be if you allow yourself to go there. And I can tell you that, in that isolation, there were times when I was definitely near suicidal because it was that bad, because I really felt that no one understood, no one knew what was going on. And here I am by myself having to fight this war that, my wife can't understand,
which goes right back into humans are social beings. So if you're socially isolated for whatever reason, and then you like do it to yourself, or not really do it to yourself, you just feel like that's what needs to happen. Like, we know that's like one of the worst things, right? For a human. And I've had numerous patients that I'm never going to know, but I didn't realize how much their pain was affecting their entire life until they voiced the same thing of like, I was on the verge. And I think it's normal because I normalize pain, right? Because that's what I deal with. I'm like, well, this isn't that bad, right? Like, get over it, or not get over it, but like, we got these tools, right? And then if it is a pain neuroscience case, like, hey, we managed it this way, but then for them, it's like, at least you had the medical background, which may have harmed you in a lot of ways because you used that, but then also helped you in the end to maybe understand it better, which is kind of coming out the back end of this. Like now you went beyond just reading books and done some self-study, was it a course or like an online study?
It's a mind-body practitioner course certification that I took.
And that's through University of Michigan or Michigan State?
No, this is out of a university. Okay. It's called the Mind Body Fitness Institute. Okay. I think it's out of Australia actually. Because I've had a lot of time. There's a lot of good people in this field right now. A few of them is Dr. Howard Schubiner, David Hanscom, David Schechter, and I have taken classes with Dr. Schubiner. I was actually in a support group with Dr. Hanscom. His book, I think, is the Doc Journey. And these people are so wise to this epidemic of chronic pain, and they're on such a mission that I believe in I think chronic pain is a solvable problem. Mm-hmm. It's just problem is it takes a long time, and it's widely outside of the traditional medical model, which is always tough to beat down. Because my one of my best stories with Dr. Hanscom is he was a spinal surgeon out in, I think, Seattle or California, and essentially he developed a program where people came in and unless they had a surgical emergency, he would not operate on them. He would get them in his program called Prehab, and what he'd do is essentially like, okay, I'm not 100% sure this is your problem, maybe, but this is what we're going to do. We're going to learn to do active meditation. We're going to do the journaling, and we're going to settle down your nervous system, because right now your nervous system is screaming. Mm-hmm. And so they would do 6 weeks of prehab and then come back. And he said, like, majority of his patients pain was so low that they wouldn't do surgery. If not, they were pain free. Right. And so essentially, he says he put himself out of business in some ways because he realized, number one, like, spinal surgeries aren't that successful. Mm-hmm. I can't remember the last data I looked at, but I think it's maybe 20-30%.
Yeah, if you have an extrusion or sequestration on the nerve, like, which is pretty easy to pick up an exam, I would say really high success rate with discectomy. Like, yes, really right. Outside of that, I mean, it's
I think spinal fusion may have been what he was talking about.
Yeah, absolutely.
But I mean, it's one of those things where it's a movement that I'm hoping to just, with my future in this, will be to help people with chronic pain, and I'm obviously in the works of trying to figure all this out, because I think sometimes when you get into deep holes like with disability and some of these other things, that it's a kind of a hard hole to dig out of. Mm-hmm. But I think I'm on a mission to help people, kind of help cure chronic pain myself, because I mean, I think I don't want people to have to suffer like I had to suffer, and my goal is to kind of help people kind of see, like, this is a problem that you can solve, and maybe we get you 40% less pain. Well, isn't that better than
much better management strategy,
right? Than where you are.
Well, the big issue is the knowledge gap, right? Like, just in the medical world, there's a huge knowledge gap, and then if you go out to the lay public, I mean, that's gigantic. It's a chasm. And then if we back up to the spinal surgeon that kind of went down the route of, like, putting himself out of business, a couple of things that I always think about in practice is a lot of data shows that whether it's conservative or, non-conservative care for pain, musculoskeletal issue, back pain, intervention usually makes people worse.
Yeah.
If we do nothing, you're usually better off. Around 60% get better with nothing.
Yeah.
Versus we actually make people worse if we intervene, even if it's thinking that we're doing the right thing. So you see stuff like that in my profession and your profession, like it kind of makes you be like, what are we doing?
Yeah.
So the first thing is, which I'm always harping on, and I think one of my missions is like, we need way better diagnosticians overall, which then you have to be aware of all the possibilities, what's creating pain. So you have to be highly aware of this stuff. And if you can, Michael Shacklock, who created neurodynamics, talks about hospitals. Like, well, is somebody in the neurodynamics hospital or McKinsey or pain neuroscience, and if you put somebody in the right hospital, you're going to have way better results overall, right? You got put into the wrong hospitals for a long time, which then probably catalyzed your scenario in the negative, versus if you would have started in the right one, it may not have been like a home run still, but like you wouldn't have had to go through all those steps and maybe made it harder, at least it took longer.
Well, I totally agree. I think I was my own enemy. I think the more interventions that we did or I attempted, the more frustrated I got when they didn't work.
Right.
Thus, that internal rage and anger and frustration just was off the charts.
Totally normal.
Yes.
When you think about
absolutely.
it. And I get it too, because people come in here usually 4th, 6th, 7th down the line, which sometimes makes your job easier because you've done a bunch of stuff, but then sometimes it makes your job harder because, like, if you don't hit a home run, right away or something, like, people are just already in their head, like, spun up, and you may know exactly what's going on, but like you said, you got to be ready to heal, you got to be ready to have an internal intervention or something like that. And that's where, going back to the surgeon, now a big part of, like, prerequisites for surgery are these resiliency scores. They won't even do surgery on you if they know that, like, well, you're just not a great candidate for, like, how you're going to bounce back, even if they know you need the surgery.
Yeah.
Like a osteotomy in your hip or something, like, you just don't handle this stuff well. Now, that's what you could try to change, right? Which is meditation, general movement, other lifestyle factors around health. But that's really hard to sell in our practice because people expect musculoskeletal stuff when they come in. So you start talking about that and they're like, I'm not paying you for that.
Yeah. Well, people expect immediate results, and that's what I expect. That's what I expected.
Well, and that's what also that's what you delivered in emergent setting medical care.
Yes.
It's literally immediate results, or they're triaged out, and you just knew, like, boom. So, like, again, so many factors that just led to, like, your subconscious being like, well, if this isn't solved, what the hell's going on? And the further you got away from figuring it out, the worse it got for you, which is chronic pain in essence.
Yeah. It was definitely, looking back at it now, I tell people all the time, it's one of those journeys that you'd be saying, are you crazy that you were thankful for that? And I was like, well, I wish it wouldn't have gone the way that it did, but also at the same time, I am grateful for it because it taught me a lot about myself. It taught me a lot about my resiliency, my strength, and conquering doubt and fear in my life. And so that's, I'm thankful for it in essence of it's been a good thing. It's really helped me see who I am and be the person that, is not running around the emergency room angry, screaming at people because we're not getting things done, and having more, and really seeing people, being able to see and read people, not just from, hey, you're coming into the emergency room because you have migraine headaches. How great is a migraine headache? No, it's they have a headache, but so what's really going on in your life? And I think that's really, in essence, like a lot of times what the medical model doesn't do very well at is oh gosh, we have headaches, or we have abdominal migraines, or all these different kind of somatic complaints. But really, what these patients need is they need somebody to say, hey, what's really going on in your life? What could be some things that are stressing you, or, who knows? It could be multifactorial, but now when I go back, if that's the direction I go, then that will be kind of more of how I practice, is really getting to understand maybe the core reason why these somatic complaints.
Yeah, we're really good at detaching the human from pathology.
Yeah,
which is not how it works at all. I mean, literally at all.
Well, because I definitely practice as the mind and the body are two different organisms. And that's how it was. Like, if you're having,
we've been taught that system, like, I mean, we're just now learning, like, you know, how much systems play off one another. I mean, just think of like gut microbiome stuff. And I mean, I just read research the other day that like they're thinking most thyroid dysfunction is like gut related, not just thyroid dysfunction. So we're still learning like how interconnected stuff is. It's just funny when we pluck out somebody's appendix and we're like, don't need that thing. And it's like, you probably do, you know, but we've always been kind of in these like silos. And again, like, I think the regression is the better you, like you said, like reading people, what's that, like better understanding humans. And then you understand like, well, pathologies reside within this like really complex organism. Like it's tough. Like that makes your job really tough.
Yeah.
But like if you owe to that instead of just like, well, no, I'm going to hone in on this. Like I've been really jealous of, you know, a friend of mine here that's a general surgeon. I'm like, you're like the most like practical application of medicine, right? Somebody comes in with an enlarged spleen or something, that's very British, you should take it out.
Yeah.
He's like, yeah, it's kind of cut and dry, but he literally, his voice, that's why I picked that. Because everything else is just so gray, it doesn't make any sense to me.
Yeah.
Which is, I was just like blown away. Super smart guy. He's like, yeah, I had to choose that because he knew everything else was just like not the way it should be.
Yeah. Well, if gallbladder is bad, you take it that, like you said, gallbladder, I mean, yeah, broken bones. I mean, that stuff it is what it is.
Black and white.
Black and white. But these, you know, weird kind of, you know, that's the thing, is just this weird progression of symptoms. And, you know, there's a lot of good books out there, but one is, you know, they can't find anything wrong with me. I think I forgot David. I can't remember the author of that, but, you know, they really go into these patients that have been through the medical model and but they end up getting these interventions and stuff that, you know, they really didn't need. But I don't know. It's hard to, you know, that's one thing. When I started down this track of looking into this, I've been telling myself, going, man, I'm kind of changing a lot of what I believe. You know, it really is, because it's a theory that a lot of people they don't really agree with. So it's,
yeah, they can still hear the information, but they're not willing to change, which is, I think, just a good trait to have the human, especially if you're going to be in medicine, because again, you can uphold your whole practice just being very bias confirming, right? Even though you may say you're not, but that's when you get on shaky ground. That's, I mean, you know, go tell a bunch of spine surgeons here in town what the guy in Seattle found, and you know, they're going to probably vigilantly fight you because that's what pays their mortgage and all that stuff. So it's tough. I mean, we even, you know, I tell our interns and stuff, like, our job is to not confirm your bias every day, which can be tough, because then you're like, again, should I intervene with this person? You know, should I? Sometimes I have to literally make the choice now. I'm not even going to touch that person, just because I know by doing that, even though I could help them, changes their, you know, the feedback loop on what they think is actually happening, right? And you just got to be, I mean, again, it's reading the person. It's not just, hey, this is what they need and that's what I'm going to do. No, like it's N equals 1 for sure. Yeah.
I think definitely with people that have chronic pain, and what I've come to is that it's kind of, you know, 3 pillars for me. It's, first of all, you have to have knowledge. You have to have knowledge that this is what's possible, what's going on in your life. This theory of somatic complaints or emotional based or what have you, and then having action steps would be the second one, of having a toolkit of these are the things that I can do to help, you know, turn down the volume of my pain. And then I think the last part for me is just learning how to go live and have fun, live life again. And so that part I'm still learning, but
reintegrating into society.
Yes. But that's kind of, you know, my moving forward is you know, is applying those principles in my life on a daily basis, so that I can get back to where I need to be.
But then you already are planning on starting to kind of help people based on that like principled approach.
Yes. No, that's there's going to be some, a lot of this is, fear. Again, if I go back to the same statement, the fear is the fuel. Like I do have a lot of fear because, this is a part of medicine that, it isn't necessarily well accepted, but it's also something that I firmly believe in. And am I going to be rejected? Am I going to, all these things. But, and the thing is, that fear, that anxiety is what causes pain. And so the struggle that I have is kind of a unique, not unique. I call it unique, but it's just one of those things where it's like, man, if I do this and, I have this is going to happen, I'm going to hurt or whatever. And it's kind of just like part of this whole process is leaning into those things and doing it. And so yeah, I mean, my goal, there's going to be some things probably I'm hoping in the next few months to get some things going on Instagram, and then maybe some coaching. Right now, if anybody wants to talk and about this kind of stuff and, needs some help, I'm definitely available to do that. So I'd love to do it.
Talking unique, I mean, it's a unique scenario that you get. I mean, there's a lot of people dealing with chronic pain. They get somebody that's been in the medical profession. That's where the uniqueness for me comes in, because I'm excited you're doing this, for an awesome referral source, but like you walking the path of being in medicine, having it happen to you, coming out the back end, which I know it's not the back end, it's a process, but of like now wanting to use all that to kind of help people the same thing. I mean, that's the rarity, right? And so people go through it, they don't have not that you have to have the classical training per se, because there's a lot of people out there doing stuff like this nowadays with no training, whether it's nutrition or chronic pain, but like it helps a lot for a lot of different reasons. So I'm excited to see what happens with that for sure, man. And we'll definitely be sending people your way. Any last bits of wisdom?
Man, there's lots of wisdom that I would like to impart, to people, but I think that's the thing with people that have pain is there is hope. I mean, that's the thing. I think a lot of people that end up in these scenarios just kind of lose hope that there's no help. There's no, there's, no. It's even hard. I get kind of emotional when I talk about it. It's just huge.
Chasm in your life, man.
Yeah, I mean, it was. When you get it to the abyss and you're down there and you're going, man, I'm never coming out of this.
And you don't even know a way out.
And but that's, the big message that I want to get across is that there is hope, and that you have to dispel unbelief. You have to, believe that you can, and it's doable. And, I mean, my story isn't quite finished yet, but, I would say with you as walking along the side of me this whole time, would say that the progression is far better now than it was, 7 years ago when I was walking in here as a zombie. But no, I mean, that's the thing, is that there is hope and that it can be done. There's just some work that has to be done, and just biggest thing is coming to awareness of what's going on. And I think that's the biggest key of all that is if we go down this model and, the medical model or what have you, and things aren't working, then, hey, maybe it's something else. And that's awareness. And then you have to come to awareness. And
a lot of patients are going to have to find that out for themselves, which is not how it should be, but that's how it's going to be for a while. And one thing I do want to point out here, because you are the first patient come on the podcast, there's a lot of docs out there that listen to this. I had zero, I would say not input, but zero the outcome, right? So where you're at now, I think I had zero. Because like I was doing musculoskeletal stuff, we had discussions. Why I say that is you had to find out on your own, which sucks, even though I don't think I was a guide at all. I think you always pulled the information yourself. But if there's practitioners out there, like you need to be well equipped, not that I wasn't, like I was well aware of pain neuroscience and chronic pain. Like that doesn't mean that I'm going to be able to treat you, like that's where you still have to be able to triage. And that's there, in my opinion, in our community, there isn't. Like there is nobody that I could refer to besides pain management, like classic traditional pain management, that I could refer to in this scenario.
Right.
That's the big downfall of the system right now, right? That's why like you coming in doing what you're doing, because even if I knew how to triage, you're going elsewhere in the nation, which we did talk about at certain points. So like, you can go do this, talk with these people, and we need way more people doing what you're doing in the face of, not only chronic pain, but I mean, opioid epidemic, musculoskeletal pain is the biggest burden in the world. Low back pain is the biggest cause of like missed work in the world. I mean, there's just a tidal wave of stuff that's only growing and getting worse. And like, this is a huge part of it, but it's still just not part of it. So it's like, we all got our job to do for sure. But thanks so much for doing this, man.
Yeah, no, I enjoyed it. I'm trying to hope that I sounded somewhat articulate. I'm not very good at it.
It's fantastic. And the cool thing is maybe we'll start doing more of these patient stories with like specific stuff like this. So people realize like, oh, there's like, again, like there's so much information out there now, but like, I'm not going to say misinformation, just the pervading information on pain, injuries, treatment is just really not great. And it's still archaic 20, 30 years ago. So I think it's cool that you're going to be, putting information out there and also doing work in the community. So. And
that's the thing. It's like, I've gone away from the theory that we just have to manage chronic pain. I think we can, get over it or heal it. It's just, takes time.
Absolutely. So cool. Thanks again, man.
Yeah, man. I appreciate it. Thank you.
Yep.